we worked together in the menopause clinic at the Riverside Hospital, and she I think started practicing menopause like when I was still in diapers. So she knows.
Yep.
She's a
Boy.
big wealth of information. She's a registered nurse with us with over 35 years. Yep, definitely in diapers. Over 35 years of experience in women's health. She's working as a menopause practitioner and a nurse with me at the Ottawa Hospital, Shirley E. Greenberg Women's Health Center. That's where her last 25 years have been spent building really a large tool chest of knowledge in menopause, mood disorders, colposcopy, gynae-oncology, and contraception. And the special thing about Helene is that she's given these webinars before when it was more commonplace as part of the menopause portfolio when Dr. Elaine Jolly was heading things up before she retired. So we've started to build the program back up again, and here we are on our first inaugural public-facing webinar. And without further ado, I'm going to hand it over to you, Helene. And we'll spend the first hour just talking about focused on Helene's presentation, and then pivot in the last half an hour to some of the questions. So we'd ask please that you post your questions in the chat. I will do my best to answer the simple ones by typing, and the remainder ones or the common theme ones we're going to collect for discussion at the end. Okay, take it away, Helene.
Hi, thanks for waiting with us and putting up with our hiccups, which may have been me that started the meeting too fast and stopped the meeting too fast. But that's what happens when you are not experienced at these lovely tools. So let's get going on managing the maze of menopause. I will try not to make this super tediously heavy in details, but try to give you the core of what's important and what most women, I'm not going to touch on everything, I don't have that kind of time, but what most women will comment on or complain about or be concerned about, okay? So my first, I'm going to play with this button instead. Okay, there we go. So basically, just our nice little legal disclaimer. We're just here to give you advice, to give you some information about menopause, how to manage things, what concerns you may have, and how you can bring them to your health practitioner to discuss what you want to do about it. Okay, so we're not here to give you specific health advice on how to manage your own care, just suggestions. So first thing, we want to talk about humanizing menopause as being part of our lives, just like, as we always said, taxes are part of our lives, life, death, all those things. Menopause is something every woman goes through. We go through it in different ways, in different paths, and different intensities. Some women cruise through it and some women don't. So everybody's different. It affects us differently. So we're going to look at the various stages and the various phases that some women will go through and some of the symptoms that come with it and the challenges that you can have at work, have with your colleagues who are either going through menopause or if you're going through it, how to help your friends, coworkers understand what you're going through and not berate you about it. Most people don't, but you never know. So over 10 million women are over 40 in Canada, 25% of our workforce, if not more. So this is why it's become more and more important, and it's become very important in the workplace to address some of the issues women are noticing and having and how to manage it. So I'm going to start with perimenopause and we'll transition into menopause. So perimenopause can start many years before menopause. So menopause is 1 year without a period. So perimenopause can start 5, 8 years before that. So meaning you can have changes to your menstrual cycle. You can have different types of symptoms. Some people will have hot flushes. Some people will have more mood swings. All of those kinds of things can happen as you're transitioning. This is what we call part of the transition. So your estrogen will go down and up. That's the big telltale sign of perimenopause. Your estrogen is on this big roller coaster, up, down like a yo-yo. For some women, dramatically. In some others, it's not as intense. So we can't tell for sure what you're doing. You can't tell for sure sometimes what's going on in your body. And that's part of the frustrations. So this goes on through all of that perimenopausal phase till you do a year without a period. So once you do a year without a period, then you're considered menopausal. And directly by the next day, postmenopausal. You're postmenopausal basically the rest of your life. Not that it means you're going to have symptoms the rest of your life. It just means you're in that phase the rest of your life. So that's where some women will have more symptoms there. Some women will have more symptoms right after. And some women have symptoms mostly during perimenopause. Everybody's different. It's hard to predict. And that's part of the challenge. Okay. So that's what we try to weather through. So as you see, this is the visuals. Your menstrual cycle's your hormones are doing that little fluctuation up and down normally in premenopausal years. So in the younger women population, I'm generalizing once again. Perimenopause, usually in your 40s, because average age of menopause is 51, 52 for Canada. So in your 40s, you're doing these wild rides up and down. And for some women, the hot flushes and the moods are the biggest challenge in that up and down. Once you're postmenopausal, most of your hormones are low. They're not doing much. They stay status quo in a slow, not decline, but they stay in this static position. Okay, they don't really change once you're a few years postmenopausal. Symptoms of menopause. I'd like to say there's 100, and that's probably what I've heard over the years, of all the various little quirky things some people may have experienced. This kind of itemizes the basic, most common ones women will notice, okay? And that's where we try to focus some of our energies in managing the worst of these types of symptoms. The biggest one, as we know, is hot flushes. Even my kids know about hot flushes. They knew it from the age they were 10 about this because I've been doing it for so long. So 70-80% of women have hot flushes. So a hot flush definition is typically from the waist up, you get red as a tomato. I'm going to get red today for sure because of just the hiccups we've had. So I know that's going to happen. I'm going to drink my water and I'm going to try to move on and plan on having a nice glass of wine when I get home. That will be my perk. So some women are severe hot flushes. So the kind, it's like an event. They end up feeling really hot. They will get nauseated. They will get super sweaty. And they sometimes will have palpitation. They feel like they're having some kind of cardiac event along with it. So those are severe, not as common, but they do happen. So you're not losing your mind. That does happen. Not to everybody, thank God. So 7 to 10 years, the usual time of these hot flushes. It does not mean they're going to be horrible through the whole time. It just means you're going to have them. I can still have them even though I'm well past menopausal years. Many other women will comment on that too. So the goal is to manage them in various ways. So it affects our quality of life. It affects our work productivity, especially if you had to work somewhere where you have to be fully dressed in a whole outfit where you'll be really hot. It could affect absenteeism, and that's mostly related to lack of sleep due to the hot flushes. You can have memory issues, mood issues. So we used to get complaints about this section of our presentation was depressing, and it can be, but there are things we can do for this. We just try to find our way through it, through the challenges of every woman. So first thing you do is you have to figure out, is it truly menopause that's causing this? You could have other health problems, thyroid problems. Some cancers can give you similar symptoms. Unlikely it's that, but we have to rule out those things if necessary. And now we're going to look at lifestyle as the first step, and then we're going to look at other things to manage the symptoms after that. Lifestyles is basically, what can we do differently in our lives? Can we change our cooking techniques? So spicy foods will give you hot flushes. Try not to cook spicy, even though you like spicy. Avoid your triggers. Now we'll talk about triggers in a sec. Exercise, relaxation, all of those things will help decrease the hot flushes. Not while you're exercising, because you're going to get hot, very hot if it's hot outside, especially, or hot in the room. That hot yoga may not agree with you at this point. So you may have to make adjustments to your exercise, just like we make adjustments as we get older because of our weaknesses or joint pain. Evidence supports that we can try cognitive behavior therapy for the hot flushes. So that's another option. It's not commonly done. It's not very popular yet, but it will come. What's not helpful or inconclusive is things like phytoestrogen, acupuncture. There's not a lot of data that supports those things are helpful, or the natural health products. There's very limited information on exactly where those natural health products are coming from, who's making them, what's in them. It's not well regulated, so what is going on with them? And for the most part, they're not super helpful for the hot flushes. Some women find it helps. I'm not going to negate that, but the data doesn't show that it makes a big difference. So we're going to reduce caffeine. We're going to reduce, so that means you can have decaf coffee, but not as much caffeinated. Okay, so just to define that, because I do love my decaf. So alcohol intake, you got to see what works, what doesn't work for you. Some people, any alcohol, some people very much red wine. Figure that out. If you notice that you have alcohol and you don't sleep well at night, or you have hot flushes at night, it's the alcohol that's contributing. So modify that. Wear breathable clothing, so natural fibers, anything you can that you could breathe in. The other thing we always said, which is not in this written in here today, but wear layers. So wear something so that if you're hot, you can shed a layer. So you can take your sweater off, you can take the extra shirt off so that you can come down, and that will cool your body. Drink some water, that will also cool your body. You can drink it or you can wear the water. I like to wear it. It helps me cool down more. So whatever works for you, cold fluids will help. Workplace temperature. So if you work in an environment that's really hot, bring some fans. I have patients who have a fan on their desk and a fan at their feet. So because it's so hot where they work, and it's a whole big environment, you may not be able to put out your 2 cents and say, can we turn the temperature down? At work, make it less taboo that hot flushes are part of life. I've gotten some of our male doctors who work in oncology to accept it and embrace it when I bring it up. So my favorite example of this one is a patient I had years ago who was a teacher, a kindergarten teacher. And whenever she got red in the face, it would embarrass her because she thought, she felt bad for the kids. So she made a game with the kids. So anytime she got red, there was one student in the classroom designated to press number 2 on the fan. It became a battle between the kids, whose turn it was to press number 2 on the fan. So it became not a taboo, it became a game to the kids. They thought it was great. So she didn't feel bad about having hot flushes as much. It sounds silly, but it works. So it worked for her. So our triggers, we talked about caffeine, we talked about alcohol, hot environment. So hot, humid days, sitting out in the sun, like when you were 20 and put no sunscreen on back in the day, that doesn't work typically for most menopausal women. So avoid those, or be aware that if you're going to a big event and it's going to be hot in the room, dress accordingly. So dress in less layers than you would have normally. Stress will make everything worse. We have women who would have multiple hot flushes when they're here in Canada in January, go on vacation for a week in Cuba, no hot flushes when they're down there. So we know stress has a huge impact. Now, in our clinic, we mostly see cancer patients. They have a lot of stress. So it's a very challenging area to work on, but it can be done. Tough, easier said than done, but it can be done. Just got to work at it. Spicy foods for some women and sugar for some women really triggers them. So again, it's figuring out what works in a good way for you and what works in a bad way for you. Cognitive behavior therapy does work. There is evidence, there is data that supports it as a tool to help decrease hot flushes and some menopausal symptoms. And it's not easy to understand exactly how this works. But basically, it's how we look at our hot flushes. Like I was giving the example of the lady with the fan, the teacher with the fan. It's the same concept. We want to look at hot flushes as not being as detrimental to our lives that maybe it feels at the moment. The more we can think about it as just a phase of our lives, hopefully the better they are. The more our brain thinks positively, the better the symptoms are going to be. And like I said, there's evidence that supports this. You need to usually use a behavioral coach to help you with some of these things. Some people will do CBT for mental health. You can use those same kind of techniques for the menopausal symptoms. So hot flushes, we know, like I said, I've kind of gone over this a little bit, but the other parts, if you look at the second and third comments on here, is the abdominal breathing, the calming breathing, the relaxing breathing. Positive thinking will work. Try not to get yourself out of social situations because you're worried you're going to have hot flushes or you're worried you're going to have menopausal symptoms. You want to keep doing things you enjoy. You just modify either how you do it, when you do it, who you go with, what you surround yourself with, all those kinds of things will make it better. It's more of an effort, but it can make a difference. If we try the lifestyle and it doesn't work for us, we will look at non-hormonal medications. So this is a kind of a blurry slide, but I copied it from the Sigma website. The neurokinin B receptors antagonist, that's the big word at this one. This is a new kid on the block, new class of drugs that blocks that neurokinin receptors, and then which was involved in your hot flushes. So this will decrease the intensity quite well of your hot flushes. So it's been studied for a while, as many drugs are, but it's only been out in Canada for a couple of months, I think. So this is a great solution for women who cannot take hormones and still really struggling. So we will use that in these women. Same with the gabapentin. So gabapentin is a drug that we can use at times for anxiety. We can use it at times for depression, not as commonly, joint pain, all those kinds of things. So this has worked quite nicely also at night before you go to bed. We do it in graduated doses. You can do it 3 times a day. We have patients that just take it at bedtime. It helps the hot flushes. It helps the sleep, which can also help the mood. So it does work quite nicely. We use it at a very low dose compared to what some people take for pain management. So this is another great option for women who don't want to take hormones or can't due to any diagnoses they can have. The other kind, antidepressants. Very helpful for hot flushes, extremely helpful for mood. So some of our cancer patients, because they struggle with mood issues due to cancer and other things going on, this is a nice option for them. Again, or other women who don't want to take hormones, who cannot take hormones. Oxybutynin is a drug that is given for bladder function. So it has helped quite well for women for hot flushes. Mostly that's where it works the best. It helps for the GSM is symptoms that are related to vaginal dryness and bladder changes that go on after menopause. Okay, so it does help with that too, but most of the effects for what we use it for is for hot flushes. So those are examples that we would use if we're not using hormones. I'm going to skip over this for time purposes. Compounded hormones. So that's the creams that you go to a compounding pharmacy and they give you. Challenges with this, there's a lot of challenges with this. It's not safety, it's not surrounded by good safety data. There's no big studies on it, and there's no safety in regards to how it's made. We don't know, the companies that make these don't have any regulatory government division that oversees what they're doing to make sure they're doing it properly and there's no contamination. There's been issues in the US with contaminations with certain products. So we shy away from it because we don't know exactly how much you're getting each and every time you're using it. But what I said to women is that if you're going to go down this road of the compounded bioidentical hormones, remember that you're taking hormones more than likely, and keep an eye on the side effects of taking hormones, which I will get into in a little bit. So keep that in mind. It's not because it's compounded and deemed natural that it doesn't come with risks. So there are risks, like it is for any medication or any supplement that we take, just like aspirin, there's risks. And the testing, the salivary testing and urinary testing, I don't see as much of that as I used to from women coming in commenting on that, but it's not reliable and it's not recommended. The results are too variable to give you any kind of guidance on how to manage your menopausal hormones. So hormones are by far the best way to treat hot flushes. For so many years, it was taboo to prescribe hormones to anyone, I swear, all through the WHI years. But now we've turned the corner and we've seen all the benefits. We've always known the benefits, but now more people are seeing the benefits. So they do resolve the hot flushes, and they do help with the sleep, and they do have positive effect on the mood. They're not earth-shattering for the mood, but they can have positive effects on there. There's various ways we can take hormones. So again, I'm going to skip over that due to time. There's estrogens. There's oral estrogens, there's transdermal estrogens, and there's part of the transdermals are patches or gels. You've got a whole slew of them listed there. And we have certain ones we use more commonly, but it comes down to what the person wants to try and what fits their lifestyle better. So certain kinds we don't use as much, and certain kinds we will use more often. It just has to do with trends sometimes. Sometimes it has to do with budget. Patients can't afford certain things, so we do have to modify because of that. So that's estrogen. So that estrogen will help most of the menopausal symptoms that we hear about, mostly the hot flushes, but many of the other ones. The other part that we often prescribe with estrogen is progestogens. So if a woman has a uterus, the estrogen goes to that uterus, stimulates the uterus to have implantation for this egg and getting pregnant. So we're not doing that right now. That's long gone. So the problem is that when that estrogen goes to the uterus, if it goes there and you don't protect the uterus, you can get into bleeding problems or you can get into abnormal changes in the uterus. So we have to give progestogens. If you don't have a uterus, you don't need the progestogens. So that's just a good solution. There's different ways of giving the progesterones. Most commonly, we give it orally. There's a few different kinds that are given orally with some good effects. Some are a little more challenging. Progestogens can give you mood changes, so we do have to be careful with some women, find some of them more challenging for the mood parts. There's an IUD. There's a few different kinds of IUDs, and they provide the progestogen directly to the uterus, so you do not have to ingest any more progestogens. Okay, so that explains that. There's combined estrogen, progesterone, what was I going to say, drugs available, oral formats, transdermal patches. Most of what we would use is the oral combination format, which for some reason I can't see my slides very well today. Bijuva is the one we will use the most. It's newer, but we also use Activel. So there's different ones. Some are more commonly used. Some, like I said, are not as commonly used. We will use Duaviv, which is the last one at the bottom here, because it has a very positive effect. It does not stimulate the breast tissue like estrogens and progestogens do. It does not stimulate the uterus like the estrogen does. So it does have a positive profile for those scenarios. And so for some women who have a lot of either breast pain or things like that, it really helps them to try that kind of drug. It was unavailable for a few years, so we've been had to pull a lot of women off of that and try to find substitutions. A lot of issues with that this year, in the last 2 years, I should say. Next step is sleep. Night sweat's the most common cause of sleep disturbances, for sure. If you get, so I did a cognitive behavior sleep the heck was it called? Therapy. Insomnia, that's what it is. CBTI. I did a course, and part of the course was mentioning that if you get less hours of sleep, you increase your health problems overall. So we are really trying to get women to get this good sleep. And a lot of women will say, if I can at least get 4 or 5 hours a night, I'm a happy camper. We'd like to get more than that, but we want to try to get consistently as an unawakened 5 hours, 6 hours, if possible. Most women have challenges with staying asleep more than falling asleep. Don't know why exactly, but you can fall asleep really well, wake up because of a hot flush. The problem is if it turns into a night sweats, you wake up, you're taking the sheets off, and you have to change what you're wearing. Some people have to change what they're wearing, change the bed, the whole bit. Some people's just take the sheets off, put the sheets back on. If you can get back to sleep, that's a win right there. If you cannot get to sleep because that wonderful brain kicks in, which it does for many of us, then that becomes a challenge because your daytime hot flushes will worsen because you're not sleeping. So we get into this vicious cycle of disturbed sleep, disturbed day, disturbed mood, and so on. So sleep, we notice in women either perimenopausal or menopausal having problems with sleep, especially if they're having hot flushes. They have problems with sleep even without the hot flushes. It's just worse if they have hot flushes. And this just shows you that estrogen will help you with that, and the cognitive behavior therapy will help you with that. The other things such as exercise, yoga will also help. But the biggest jump is the cognitive behavior therapy, amazingly enough. Works in women and men. So what can we do? So we look at the sleep hygiene. I'm sure most of you have read about sleep hygiene, the no blue light, no artificial light. So the things they taught us in the class I did was whatever time we had to do a whole schedule, mark down every night how we slept and what time we woke up. You're supposed to keep waking up at the same time every day of the week, regardless weekends, or weekdays. Try to limit artificial light in the evening. Try to dim the lights. Even if you don't do the screens, try to still dim the lights and turn lights bright in the morning. Yoga, meditation, relaxation will all, be beneficial to this. You just have to figure out which one works for you. We all have techniques that are more helpful than others. It's figuring out which one, and it's practicing. Other medical issues, you could have sleep apnea. Your partner can have sleep apnea. Your partner could have other issues of restless leg syndrome. Either you have it or your partner has it. So it's figuring out what else is disturbing your sleep, not just menopausal transition or hot flushes. There may be other things. I hate to throw partners under the bus here, but that can happen. You can have, we know lots of women who sleep in separate rooms as their partners because of those kinds of issues. And once that happens, they do sleep much better. Next phase is the mood. So we're going to take a closer look at depression and mood in women. And depressive symptoms, anxiety symptoms do tend to go up in our later years in life. Not for everybody, but there are some challenges that arise at that point. We have unique psychological stressors, psychosocial stressors, I should say. Transitional roles. So that's where you have elderly parents you have to help. You may have children at home. You have children that were home, went away, and came back. You have children who may have challenges for various reasons of their own. We've seen a lot of increased mental health problems in younger, not just say children, but young adults. So all of those things that women tend to take on and have to deal with. So you add that to the lack of sleep, the fluctuation in hormones, the fluctuation in mood, that can make everything more challenging, okay? So there's a big interrelation. Okay, I just want to make sure this was the next slide. And the focus on here is the interrelation between the four little circles: your mood, your cognition, and your sleep. And the red one in the middle is vasomotor symptoms, which is basically hot flushes. All of those things interplay. So when you're having struggles with all of the areas, things become way more challenging. So we have to figure out for each person, you have to figure out for yourself, where are your biggest challenges and what can I do to help those things and how can I improve those things? And hopefully the other round circles will not become more of a problem. Okay, so that's why we have to figure out, is there medications that you need? Is there hormones that's going to help? Is there definitely therapy is very, very helpful for many, many people going through these phases. So, like I said, all these are interrelated, right? So hot flushes contribute to the sleep problems and then to depressive symptoms because you're not sleeping. You're not sleeping, you're not able to do your day-to-day activities as per usual. You don't have the same focus at work, all of those things. So that can be the challenge. If you have a lot of hot flushes in perimenopause, and then you think, oh my goodness, I'm going to be doing this for another 5 or 10 years, it does become a little bit overwhelming at times. And it's recognizing, how do I address that now? How am I going to address it later? Same with the sleep. How am I going to address the sleep now and for the future? We're not making changes typically that are temporary. These are more long-term changes we're trying to introduce. Mood changes, I'm going to get into a bit more. We don't see as much major depression, although they do talk about it a lot, especially if we speak to any of the psychiatrists that deal with women that have different hormonal changes and mood changes at the same time. Those are challenging. Cognitive issues. Memory is the biggest complaint we see amongst perimenopause and early menopausal women. So it's that ability to focus, to concentrate, to remember things, remember people, remember phone numbers, remember words. And it's the speed at which you can remember things. It's still in that brain. We don't all have dementia, although we think we do. We worry that we do. But it's the kind of slow, foggy brain. We hear it a lot also with our chemo patients, but definitely you see that. So you need to sometimes be aware, and you may have to tell others, I know the answer, just give me a sec, it's gonna come. It's just, we talked about, it's the Rolodex in your brain, for the old ones of us that know what a Rolodex is. Rolodex in your brain, it's in there. You just got to get to the right little Rolodex section of it. It will come. So try not to berate yourself for this challenge. It does become difficult in certain work environments. So make more notes, take more notes, take more, put things aside, categorize your day differently to limit the amount of stress that this can bring on to you. Verbal memories affected by your estradiol changes, your hot flushes, your poor sleep, and your mood. So we know there's that interplay again. So exercise can improve these things. And for the cognitive function, for the mood, and for the sleep, there can be for some women a help from the hormones. And that may help for later in life in regards to your cognitive functions. That's still up for debate. Self-care, there's a bunch of things. Sorry, just going to check the time. There's a different areas you can go to for help, as in finding your own way through, using tools such as different apps. They have some good apps for just cognitive behavior, for moods, for cognition, for sleep. So physical activity, I'm going to harp on this all day, all night. I seem like I do that every time I do these talks. It does help to reduce your mood issues. It does help the sleep for sure. Just don't do it within 3 hours of going to bed. Typically, that's not good. It will uprise you as opposed to down cycle you. There's websites you can go to get more detailed, and there's workbooks to help you with the mood and the cognition issues. So now we're going to move to the, as I say, the other end of the body. So menopause, you have all these hot flushes right before menopause, at that menopause, 1 year without a period, then after menopause, and then things settle down. Most women will have the occasional one. I've inherited all of my mother's turtlenecks because she can't handle them anymore because she gets hot when she wears them. So be it. Now, what does tend to happen later into menopause is vulvar and vaginal changes. Not for everybody. I hate this word, genitourinary syndrome of menopause. They decided that was going to be a good word to group all those body parts together. So we're looking at the whole vaginal area, the vulva area, and the bladder. So you'll have changes in regards to, in the genital area, you'll have dryness, vaginal dryness, you can have vulvar dryness, you can have burning, you can have irritation, you can have discomfort. Most of the discomfort's related to intercourse. So those are all the things that estrogen reduction that we've seen, usually past menopause, starts to do to the body. It's not typically a problem you have to deal with, but for some women, it becomes dramatic. Some people, it hurts to walk because it's so dry. So little things like that. Most of the women, it's more related to intercourse purposes, that they notice things. Otherwise, it's not bad. Some people will have more infections, urinary infections, or vaginal infections. That also can be related to this dryness. Sexually, what the impact is you have a decrease in lubrication. You can have dyspareunia, pain with intercourse, and you can have impaired function. So it does affect some women's ability to have intercourse. That's more in the extreme cases, but most of the time it's the difficulty with pain and the difficulty with penetration. We have different products that can be used. These are mostly just examples of lubricants. I'll talk about moisturizers in a sec. But there's all sorts of things available that out there. Try to keep it simple. Try to not add any, some come with, it's going to come to me now, but cayenne pepper in the products. For logical reasons, please don't use that. It's going to hurt. So the vagina has changed. The vagina is more sensitive. So it will be more challenged to accept certain products. So the simpler they are, the more water-based or oil-based in certain circumstances they are, the better they will go for intercourse. So the moisturizers are products that use, so Dr. Jolly's famous statements, it's oil of Olay of the vagina. So for those who remember oil of Olay back, they still have it now. But so basically it's a moisturizer that, like we would use for our face or our bodies, you would put that in the vagina. You use it 2 or 3 times a week. So it reduces friction. It helps bind some of the water and retains in the mucosa. And it makes a bit of a film so that for intercourse purposes or abnormal vaginal discharge, as someone may have that when they have dryness, this can help. So they have various kinds. We've listed some of the kinds here that are most commonly found in Canada. So Replans, Gynotrof, and Repagyne. 2 of them have hyaluronic acid, and the other one is just a polycarb kind. So finding the one that works, they take 6 weeks before they make any effect. So give it a try. If you're having problems, try it. You use the moisturize 2 or 3 times a week, and you use a lubricant for intercourse, and then 2 months down the road, see how it goes. You got to do it though. If you don't, it's not going to work. If none of this works, you go to vaginal estrogen. So vaginal estrogen, because I get this referral a lot, for most women, you can use vaginal estrogen without any risks to the rest of the body. So we're not worrying about breast cancer risk. We're not worrying about uterine cancer risk or ovarian cancer risk for most women. I'm not saying everybody here. So most women can use this very safely. It does not go into the whole body. It does not give you any effect to hot flushes or to sleep. It's not going to improve any of that. It's meant to help the vagina hydrate better, much more comfortable for intercourse, no abnormal vaginal discharge. Some women do have a bit of tearing of the vagina, so they'll bleed a little bit. So this can help with that. A lot of elderly women use a vaginal estrogen when they put in their pessary for their bladder. There's another one, which is Intrarosa, which is DHEA, and that's different. It's not estrogen. It's more along the lines of an androgen. So that works quite nicely. We use that a fair bit in our breast cancer patients with the permission of their oncologists. So there's various things we can do. Okay, why is it not slide? There we go. Sexuality. Sexual relationships, sexual and relationships are very satisfaction are very important to most couples. Okay, so it's not just the sexual, it's that combination of tenderness that you have between you and your partner. Sexual response changes with age, not just with menopause. There's an age-related thing there, that things change for you, changes for the partner also. Frequency of intercourse will decline typically with age. Again, I'm being generalizing here. Sexual activity is strongly linked to your overall health, both women and men. If the man's having all sorts of health problems, the interest is going to be low on his part, or ability to have intercourse is going to be low on his part. So it's all sorts of things. When you're not feeling well, when you're dealing with all sorts of health problems, sex is the last thing on your brain. It's down at the bottom of the to-do list for today. It's not there. So you have to acknowledge that challenge. Fatigue can be a big portion of all this. If you're not sleeping well, you're having a lot of hot flushes, or you're having mood changes, you're not going to have a lot of energy for that sexual activity, again, at the bottom of your list. One of our doctors used to always say that in your to-do list, it was one of the last items. Unless you're in a new relationship, then it's the top item in the new relationship. So partner issues, if you're not having if there's a lot of relationship issues that cause sexuality changes. So we don't want to underestimate how much power that has. We know that continuing vaginal intercourse does provide some importance in the sexuality, in the health of the pelvic organs, the vagina, and so on. But you do have to have some willing partner, usually, or for some women who don't have a partner, they can use masturbation to keep the tissues healthy also. There's different things you can try, different things you can chat about with your health practitioner. Testosterone. Another thing that's coming up tremendously these days is testosterone. We don't have any officially approved products for women in Canada. I think the only country is Australia. Lucky them, they have products. We don't. Officially approved. We do walk on the side of using products that are given to men and give it to women. We're technically only supposed to give it for low sex drive. So hypoactive sexual desire disorder. It's a big word. Taking estrogen that have this disorder, we can add testosterone. Now, there are some doctors or some areas that are using it more freely for other reasons, but technically it's only supposed to be for that. There's various formats, oral and gel. We mostly use gels these days. The androgel is the one we use most. I've seen some andriol, but not as much. We measure the testosterone levels every 3 months, or at least after the first 3 months of use. If your testosterone's really high, there's side effects to that. The side effects are hair growth where you don't want hair growth, hair loss where you don't want hair loss. You can have change of your voice that's permanent. You can have all sorts of other little things, more acne, some of your cholesterol levels can go up. So we don't want to underestimate the impact of testosterone. We have to be careful how we use it. There's not enough evidence at this moment to use testosterone for other reasons, such as low energy, low mood, fatigue, or brain fog. Not to say that it's not coming, not to say that it's not being studied, but it's not commonly prescribed for that yet, and there's not any big evidence supporting that it's going to be helpful. So nutrition, weight, and metabolism. I have no idea where I am on time. Okay, not bad. So weight is a big issue that women bring up in menopause, and I hear you loud and clear. The way we ate in our youth, and the way we naturally kept active doesn't really work well anymore. Your calorie intake cannot be the same unless you're doing exemplary amounts of exercise, and I'm talking a lot of exercise. We have to modify how we eat things. So we're going to reduce our empty carbs. We're going to eat more fats of the healthy kind, more protein, Women tend to lack in protein, so we're going to do more protein. And we're going to reduce processed foods and processed sugar, and including any kind of drinks that I see this more in the younger generation. A lot of women and men drink a lot of the juices type of, they get a lot of calories out of juice or out of smoothies. So you have to be careful of that because the sugar in that can be fairly high, and that doesn't work as well in a woman's menopausal body. So keep those little things in mind. What ends up happening is women do, for the most part, gain a bit of weight. What happens is the distribution is different than it used to be. You're losing fat in certain parts that you had fat in before that were not bad, but you're gaining this visceral fat, which is the bad kind of fat that gets in between the organs in your abdomen. This increase in abdominal fat or visceral fat starts in perimenopause and continues after menopause if we're not careful. So our lean body mass decreases. So what the lean muscles that we had are not as dominant as they were. And that's in part because of the estrogen androgen ratios are changing. So that's a complex, which I don't fully understand either, complex explanation of this weight and how the hormones are impacting that. So our reduction in oral intake, as in our food intakes or our juice or liquid intake that are sweet liquids, does have to change because of those things. So we don't end up with that visceral fat, because the visceral fat's what gives you more health problems in the long run. But that's where everybody comments, I have more fat in the abdomen than I did before, and I've lost some of my leg strength and leg size for the abdomen. So we try to integrate, and again, when I talk about this is long-term stuff, try to integrate the change in diet. We know that, but we also have to introduce activity or other ways to stay physically fit in our days so that we don't end up gaining too much of that visceral fat, that abdominal fat. We want to try and reduce it. So we try to do the best we can. It's hard to do when you're not sleeping well, you don't feel like eating the right things. Like when you're nervous and you eat chocolate, I have a chocolate bar sitting right beside me for after. So that's my treat. But that's the kind of thing we have to be careful when we're not sleeping well or our moods are changing. We have a tendency to go towards the empty calories, the ones that make you feel good temporarily, but long term are not a positive thing for you. So lunchtime exercise, go for a walk with one of your partners if you're at work. If you work from home, find someone else who's working from home and go for a walk. I mean, we're in the perfect weather, but you can do it any time. If you're going to work or you want to go to the gym, go to the gym. If you want to go with somebody, it really helps to do anything with somebody else because they will push you or they will motivate you. You will do that. Okay, well, they're going, I got to go too. So it does have that motivation. It will decrease your risks for other things, cancer, heart disease, your cholesterol. So all of those reasons are why. Strength and flexibility are essential to our work schedule now, to our workout schedule, I should say. We need the cardio for the heart, for sure, and for the brain and for the calming effect that it has. But they're showing more and more now the strength, which any kind of weight-bearing exercise, you don't have to go out and do some wicked weights that like men do. You can do it with simple, I did the weighted vest thing today when I went for a walk, so you can do simple things like that. So any kind of strength training will help you in many ways. It can help some of the menopausal symptoms, so they say now, which is a newer thing. It can help sleep. It can help sexual function because you feel better and you have more muscle. It will help your flexibility. It will decrease chance you will injure yourself. It's really good for your bones. So resistance training, so when any kind of weights, high intensity interval training is also a positive in a different way, especially if those you can combine with any kind of weights. So we're talking about this in menopause in a way, more for the osteoporosis, but also very good for your heart, cardiac wise, because your cardiac risk for disease does go up once you're menopausal. You'll see it in the slide. So this explains some of the books to help you work on the weight, because I know it's a challenge for many women. Heart health. So what you need to know, 1 in 3 women die of heart disease and stroke in Canada. So it is still a dominant thing, even though I work do a lot of oncology. We still have to remember cardiac disease is pretty dominant in the women in Canada, North America. Throw in the Americans, why not? We know they have issues just like us. So the concern at this juncture in life is that when you get older and you get menopausal, your cholesterol can go up because of the change in your estrogen. So your risks for cardiac events, not right away, typically later. You have it maybe 5-10 years later, you'll start having some cardiac problems. They might be minor, they may be more significant. So we want to look at those things, look at your risk factors, look at what you're at risk for, look at your family history, look at what the women have in the family, the stroke risk, make sure you keep an eye on your blood pressure. All of those things tend to creep up more after menopause. So we want to keep an eye on those factors, including the weight, because it increases our cardiac risks. It's not good for our blood vessels. Symptoms of heart disease, I will not get into the specifics of that. You can see it in the slides afterwards. In women, as we know, the symptoms are different. They tend to not have the big chest pain like men do. They tend to have more the stomach, the front chest discomfort, or the back discomfort. They can have the radiating to the jaw. They may not get that. Women do have more of the mild or vague to interpret symptoms. Now, I'm going to talk a little bit about breast cancer, because it does concern a lot of women when they think about hormones. Again, if I go back to the beginning of my career in this, it was so taboo for anybody with breast cancer risk to take hormones. So now we know the biggest risks that we have tend to more have to do with genetic mutations, especially in the BRCA mutations. And then if you have a very increased breast density on mammogram, so those are big risk factors. If you have first-degree relatives that had breast cancer under the age of 50, those are high risk. It doesn't mean you can't take hormones. It just affects how we prescribe it, and it may affect the length of time that you take it. If you take it 5 years, it's typically deemed with no real increased risk of breast cancer. You still want to do your imaging. You still need to do your mammograms or ultrasounds, whatever else is recommended for you to do. You still have to keep an eye on that. If you choose to use hormones past the 5 years into the 10 years and so on, your breast cancer risk does go up, but it's not significantly. So we have to keep those things in mind when we talk about hormones. So it's definitely something to be aware of, but it's not something to panic about if you have breast cancer risk. If you've had breast cancer, different story altogether. So everything I've talked about in regards to physical activity, weight management, diet, watching what you drink, and alcohol, and all those things all help your all cancer prevention. So we're talking colon cancer, we're talking lung cancer. I have to throw in the do not smoke part there. But all of the kinds of cancers we're seeing an increase in colon cancers, all of those in women. All of those things to keep in mind. So these are just basic recommendations that we have for cancer prevention. Osteoporosis, something that is significant. So it's compromised bone strength. As we get older, it's for some women younger age for other reasons, their bones become fragile. So you'll see how dense the normal bone is, and then you see how the osteoporosis bone is very, very thin in parts. It will fracture very easily, and that's the concern. It doesn't usually happen to most women at 50. It will happen later in life. But what we want to do is maintain our bones. We don't want to have to grow more bone. Complicated to do, takes meds, significant meds. So we want to try to maintain some of it. You'll lose some of it, possibly at menopause. Most women do, losing that 2 to 3%, sorry. But for most, it stabilizes to good bone quality and bone density. So that way, when you fall, you don't break. You just fall and bruise. We want you falling and bruising, not falling and breaking. So you look at your risk factors. Major risk factors, over 65, many, many years without a period. So these would be your like ballet dancers or triathletes that don't have periods for years when they're young. Family history of osteoporosis, vertebral fractures, so fracture in your back, spontaneous, for no reason, not like I was in a car accident and I fractured my back. Any kind of fragility fracture, so that means from a standing to falling, you break something significant. So all of those things are major risk factors. If you have a major risk factors, then you can discuss with your family doctor or health practitioner whether or not you should get a bone density test to evaluate where you are right now. And then usually they want to redo it a couple of years later to see changed. We want it to stay steady. And that's why we do the, oh, sorry. I want to go back. So that's why we talk about managing the osteoporosis risk factors by taking your calcium, your vitamin D, we don't get enough in the sun, and then your weight bearing exercises. That can maintain your bone density. If you're in an age group that can take menopausal hormones and wish to take menopausal hormones, so women that are newly menopausal, forgot to say that earlier, that are newly menopausal, so within 10 years of your last menstrual period, usually qualify, if they're having symptoms, to take hormones. So in a woman that may have osteoporosis risk factors, that can be part of her decision making to taking hormones or not taking hormones. So hormones can be helpful for the bones. If you can't take hormones, you just stick, or even if you take hormones, calcium, vitamin D, and exercise. So that's the bulk of the explanation for that. But do keep in mind that if you, like I forgot to say earlier about the hormones, there is that window, we call it a window of opportunity. So when you are early menopausal, so after the age of 51, typically, after you've done a year without a period, you can easily qualify to take hormones if you don't have any risk factors and you choose to take them for your symptoms. If you're 10 years past menopause, it's too late to start. There are some risk factors with starting late, mostly related to cardiac things. So in perimenopause, it's a little more of a challenge as to when to take hormones, if to take hormones, and how helpful can they be. So that can be a little more challenging to figure out. Women that are perimenopausal having a lot of symptoms that are 45, if they're healthy and they don't have any risk factors, they can take the birth control pill. That can help their symptoms quite well. So that was my side tangent to back to the other thing about hormones. So take home message is look at your risk factors, look at what your symptoms may be, look at what you want to do. How are you going to address it? What could work for you? What could not work for you? And then you discuss it. Hopefully we'll come out with more coaching, menopausal coaching options out there in the world. So someone could coach you through this, or talk to your family practitioner or your health practitioner, nurse practitioner, whatever it may be, to help you work through this. There are doctors in the community that deal with menopausal challenges and can easily go through this with you, but it is, a wait time to see them. So if some family doctors are quite comfortable dealing with this. All right. So if there's anything, that's it for me. Emily, I'll send it to you. I saw a lot of comments, a lot of questions. I tried to ignore it, but my ADD brain kept going to look at the rest of the questions.
Thank you so much, Hélène. That was a really great overview. We've had a lot of great comments in the chat, and I've done my best to try to answer some of the things that have popped up that I felt like I was able to answer. One of the things there was a few themes that I wanted to alight upon, and I'll fire them your way. But before that, I also just wanted to say there are some healthcare providers in the audience who are physicians or nurse practitioners. We will be having a healthcare provider specific webinar as well, just to address some of the more higher level, like medicalese questions around menopause. So that will come out probably for the fall. But thank you for attending anyway to lay the groundwork. So, one of the things that came up for sure, a lot of folks are interested in brain fog and weight gain, those nebulous symptoms that can happen that are very
Mhm,
frustrating and difficult
mhm.
to treat. What are some tips that you give patients who are struggling with brain fog?
So, for me, brain fog is very interrelated, and I see this with a lot of women, not just me personally, with sleep. So, if the sleep has been affected and is not enhanced as an improved, that brain fog can continue to be persistent. The other parts that can be very helpful is understanding that yes, your brain is not potentially functioning to its full power capacity as per usual, and it's just giving yourself more reminders, more notes, documenting your day more in detail. The has to happen this morning, this has to happen this afternoon. So more tips that you have to put out so that you don't forget anything and you don't get stressed that, oh geez, I forgot this part or that part. I think that may help some of the brain fog feeling. It's hard. Brain fog will be better if you exercise, but you have to have the energy to exercise. If you're not sleeping, you don't have the energy. So if you're not sleeping, and if you're having a lot of hot flushes and you qualify to take hormones, my thoughts are always go to hormones, try that, see if it makes a difference to the brain fog. But brain fog is a really challenging one to work through, I find. I don't know, Dr. Del Perry,
Yeah,
else to add to that one?
I'm echoing your sentiments. I have something to add, but I wonder if while I do that, if you'd be able to put up your slide that has the books that you wanted to suggest about weight management strategies. Some folks were asking for those resources again. Perfect.
Yeah.
Yeah, so I wanted to say, so brain fog, is one of those things that's very far reaching and yes, very related to sleep. We do have demonstrable changes in the brain function and executive function in women who are going through menopause. It's an objective finding that we see. It does not mean you're on a slow decline to dementia. That's one of the things that causes people a lot of anxiety. But we know it's the brain adapting to the new hormonal environment, and it's still actively being researched. Finally, we're paying attention to this, and the research has a long way to go to elucidate why it's happening as well as what to do about it. Because of course we can try to address some of the other menopausal symptoms and address the sleep disruption, but even so, even if menopause hormone therapy is added, the brain fog can still persist despite
Mhm.
locking down the sleep and exercising and teeing up all your lifestyle adjustments. So I just wanted to mention that. I also wanted to mention that the overlay of ADHD and mood changes is also very common. ADHD is becoming a more recognized phenomenon in medicine, and the recommended therapy is very much still first line assessment for ADHD and the first line medications like Vyvanse. Although I'm not, as a gynecologist, I don't have access to those medications, but I have seen the research come out that they can be quite helpful if you meet criteria for ADHD. And the other thing about mood is that it can arise even if you've not had trouble with mood and anxiety before. And particularly within the perimenopause transition, hormone therapy in
Mhm.
conjunction with the usual standard approaches to depression and anxiety, like cognitive behavioral therapy or some of the medical options we have, like antidepressants, in combination can all work together in synergy to improve a person's response as best as possible. The farther we get into the menopause transition, the less likely it is that hormone therapy will help with the mood and anxiety piece. But certainly in and around the time of the final menstrual period, we can see some benefit. I hope that addresses some of the concerns about brain fog, ADHD, and anxiety, which are for sure real. Helena had a good question that just popped up and it vanished from my chat here. Oh yes, so you and I work together quite a bit. How do we
Yep.
address patients who come in who say have had a hysterectomy but still have their ovaries, or patients who have an IUD and maybe not getting their periods or on the birth control pill? How do we assess where they're at in their menopause transition?
Okay, so That's a tough one. No, we
It
we
is.
have, and I know there's different schools of thoughts on this, and over the years I've had different physicians having different opinions on it. So we go with symptoms and we go with history. So how long have you had hot flushes? Are you having hot flushes every day? Are they cyclical in pattern? Because they can be cyclical in pattern. If you still have your ovaries, they're still intact because the uterus is gone and the uterus has got a IUD in it. So we look at those kinds of things. If we can see maybe a pattern over months of what your hormonal body is doing. The other way of doing it, obviously, in adjunct to that, is hormone levels. But I know that's very controversial. Some people love to have their hormones checked. The problem is that the hormones, like I've said to people, the hormones tell you what's going on this week, not next week. So you don't know. You know that this week you're not menopausal, your hormones look like you're 25, but next week you're menopausal. So it just depends when the test is done. And if we don't see a pattern of you get, 2 or 3 tests done a month apart, then we can't tell where you are for sure. But time will tell mostly. If historically you're having more and more symptoms, we know typically you're getting closer and closer to what would be deemed menopause, as in when you're without a period, which we can't tell because you don't have a uterus or your uterus is busy with the IUD. Then we rely more on some blood tests, but I wouldn't want to do all blood tests repeatedly, which some people want to do. Does that answer the question?
Yeah, I would say it's tricky. I agree, it's tricky and not straightforward. We do go by symptoms, and generally the clinical distinction of 1 year no period only really matters for us when we're looking at how worried we are about bleeding. If someone bleeds after a year of no period in their menopausal phase of life, we need to look at that and take it seriously as not just a period, but rather postmenopausal bleeding with a higher chance that maybe there's something untoward happening in the uterus. That's really the only distinction, and the need for contraception, of course. But in perimenopause and menopause, because those symptoms are the same, we still would offer to treat patients a similar way. But it's still frustrating for people not to know exactly where they're at in the transition.
Yeah.
Sometimes people want to come off.
Some people find that when we treat them, they kind of go through phases where they feel like they have too much hormones, and then they go through phases, or at least that's their interpretation.
Yeah, very true. I'm looking for lots of great questions in the chat. We're probably not going to be able to get to all of them. Marisa, one of the questions popped up that someone's trying to listen to what we're saying, but also pay attention to the chat if the chat transcript will be available afterwards. I don't actually know if it will. I know the recording will be available, so there will be at least some way to review what we talked about.
Yes, so definitely the session was recorded, and I will ensure to circulate the link to the recording to all registrants post-session. I'm not sure about downloading the chat, but I will definitely attempt.
Because I'm not sure if there might be privacy issues or something like that.
That's the only, yeah. So I will have to see how it downloads and if I could potentially revise it. But if it does exactly indicate any names, I will not circulate it.
Okay. Helen, joint pain in menopause.
Oh, that's a good one. If we could figure that out, that would help me.
Tell us more.
Well, joint pain, we know joint pain is part of menopause for many, many women. The challenge is some women find, and we used to have patients that would not come off their hormones because of the joint pain, and they'd be like 70 years old that would come off their hormones. So it's definitely an issue we see. It's not that arthritis is worse, or it's not that your joints are getting worse. It's just that they ache more. They tend to have, you have more, what they used to say, arthritic-like pain. So exercise, it doesn't have to be fancy. Make sure you stretch. Learn that one the hard way. But yes, magnesium can help with someone talked about 3 and 8 1, but magnesium can help with joint pain and muscle pain with exercise. But basically, I find, and for most women, if they stay active, and physiotherapists will say that, if they stay active any way, shape, or form, the joint pain will improve. You may still look like you're 90 years old when you get out of bed in the morning, but in your day, the joint pain should improve. Like I said, for some women, they do find that the hormones do help with that, but it's not an indication for which we prescribe the hormones. So exercise, physical activity, could be yoga of any kind, like any kind of exercise will decrease the joint pain, increase the flexibility, increase your range of motion, and decrease chances of falling. But that's, only goes so far when you're having severe joint pain. Then you're looking at meds, the rheumatologist's style of meds, potentially, other than Tylenol.
I'd agree with that. I think I have patients with very varying responses to using hormone therapy to help with joint pain. They feel like a new person. Other people really don't find any difference. And certainly that's supported by evidence. The evidence is kind of equivocal, meaning that it's not really a strong response associated with using hormone therapy. Some questions about supplements, like natural supplements in the chat about creatine or other options, and we don't really have a good solid evidence base for us to recommend things strongly. And for sure, there's a lot of information out there in the TikTok naturopath world that will hang their hat on very low level evidence, but we're not able to make strong recommendations in this setting. So I would be careful about spending a lot of money on supplements when there's not a lot of evidence behind it. The last thing we would want to do is do harm to your pocketbook, but also to you. There are very good guidelines that exist through the North American Menopause Society, or it's now called the Menopause Society. And they have for patients or for public consumption, information about what lifestyle adjustments or complementary alternative medicine techniques can be used that do have some evidence behind them.
I find that the Australasian Menopause Society website has a lot of information for women struggling with symptoms or different questions. I find that their information, same with the International Menopause Society, which I believe they share similar information. I find them very good resource for women to understand more. So if you want more information, that'd be definitely a great website to go to get more details on certain topics, because they definitely have all sorts of different topics we just briefly touched on or not touched on at all.
I also think there's been some requests about knowing who the menopause practitioners are in Ottawa, and for sure we struggle with this on a daily basis. There are only a handful of us who are subspecialist gynecologists who have a focus on menopause, and we're doing our best to try to educate the more general practitioners to be able to do simple hormone therapy in patients who are otherwise healthy. But what we can do is perhaps, Helen, you and I can put together a little list to circulate to the guests afterwards, just of names of people we recommend. That said, the wait times can be quite long in the public system. So there's that. And the other thing that people come up against is it takes a long time sometimes if the physician or the nurse practitioner doesn't see the validity of a referral that you've asked for. And my only encouragement could be to say that, you were at this webinar and you really identify strongly with some of these symptoms and you have more questions. And if the person taking care of you is not equipped to answer those questions, it's very reasonable to ask for a referral for a second opinion. But what they might also be facing is the fact that there are very long wait times in the city. However, that's not your problem. Your problem as the patient is to advocate for yourself. So we'll try to give you some names where you might be able to seek some help. There is, from the mental health standpoint, there is
Better Bria?
Better Bria. Yeah. There's a virtual clinic that is like a public-private hybrid. It's called, I'll type it in the chat, Better Bria. It will come up if you type it into Google. What it is they have a phone call with you about your concerns and screen you to see if they can help with the mood, anxiety, or ADHD type symptoms that are being experienced in the menopause time of life. They're dedicated to women's mental health throughout the reproductive life cycle. So whether or not it's like postpartum, but it also addresses perimenopause. They will also decide if you're better down the psychology route, which is often private pay in our current system, unless you have amazing insurance, or psychiatry, which would be OHIP funded.
There is a lot of I forgot to mention this. There are a lot of health employers that have EAP programs that can channel you to different services that will do some wellness support or coaching that can be helpful in menopause, perimenopause, and other topics such as the sleep, such as the mood, the cognition. So they do have in different employers, like we have that with our employer here, but many employers, many big employers, I couldn't speak for the little ones, do have EAP programs that you can access some services for free. May not have exactly what you need, but it might be some worthwhile, to check it out and see what they can do for you.
I will also say, just for the edification of the group, I know, Helen, you mentioned this, but the average age of menopause in Canada is around 51 to 52. But if you were to go through menopause at the age of 45, that's still considered normal. From 45 to like 53, 54 is the usual umbrella where people go through menopause. So people who are in their late 40s, you're not too young to be experiencing symptoms, even if you're still getting periods. And there are people who go through menopause earlier than 45, and those folks tend to require a bit more attention for hormone therapy, because we're hoping to replace some of the hormones that your ovaries would otherwise have been generating for you. So it's less common under the age of 45, but not impossible. What other questions can I ask you? Oh, someone asked if there were any sheets or PJ recommendations for hot flashes, or I should say night sweats. I don't have any specific recommendations. Helen, have you come across any good ones? Some of my patients really swear by cooling blankets, but that's perfectly anecdotal and not evidence-based.
I've had no, most of everything I've heard is either, I've heard the bamboo sheets, as someone's pointed out now. I've heard of bamboo sheets, and there was something that came out of Kingston. I can't remember what it is now. But I think it's more related to fans, different kinds of fans, or different kind of materials that were more breathable. But I haven't seen anything that's been quite earth-shatteringly good that women will say, wow, this really worked. It's all in that keeping the area cool. I said to a patient the other day, she goes, I have air conditioning. I said, that doesn't matter. You need a fan in your bedroom, or you need two fans in your bedroom, one on top and one beside. So it's a lot with the air circulation. I find that women do notice the difference and improvement, but I haven't, like I said, I've heard the bamboo sheets, but I haven't heard anything else that's super helpful, other than maybe not having anybody in bed with you. Because that heat the other person generates,
Yep, the snoring partner. That'll win every day.
Yep.
Okay, how are we doing for time, Marisa? I know we started a little bit late, but
we start late.
Let's see.
We started a little bit late just due to the technical hiccup. But it's currently 8:33, so I'm not too sure if you want to just give a little additional time, just because we started a little bit later, just to review the chat and the Q&A.
Yep. Let me just scroll down. Oh yeah, so some things have come up a lot around migraines. Helen, migraines and perimenopause. What do you have any thoughts about that, or should I take this one?
Well, I'll do real quick and then you take over, but because I was going to say it's usually cyclical migraines. Like I remember when Dr. Kuntz used to work with us, she's a big migraine sufferer, so she's also very knowledgeable on it, but she was very, very focused on cyclical aspects of the migraines, with or without aura, all those kinds of things, what has worked in the past. And for some women who did not have migraines with aura, she would prescribe birth control pill to kind of, or during their periods, give them some estrogen to kind of keep that estrogen from dropping too low during their period so that they would not get migraines or decrease the intensity of the migraines. But that's a fine line to walk. Not easy. Neurologists are not thrilled when we say stuff like that.
It's I think the things are turning a little bit, and like we are as a Western medical society, understanding the validity of hormonal fluctuations and their impact on women's health. Migraines that are cyclical for sure can exacerbate in perimenopause with relief when menopause happens. Or vice versa. Some people have worsening migraines when menopause starts, and we don't understand exactly why that is. The value of hormone therapy is variable. It's not a contraindication, meaning if you have a history of migraines, hormone therapy is potentially accessible for you if you're having other symptoms. But often a lot of my patients require the help of a neurologist, even for the other non-hormonal strategies that are many, but are sort of beyond the scope of a menopause practitioner or gynecologist. Though it's not to say your symptoms aren't real. It's just often we need a bunch of avenues to address the folks who are very symptomatic.
Exactly. Yeah. I agree.
Great answering questions. It's nice to see the engagement. There
was a question about food, balancing your hormones, but I don't think that many foods other than caffeine but that's more symptoms, not particularly affecting your hormones. Have you ever heard anything about food?
I didn't see that specific question. I know there are certain, like for instance, soy as one of those things that's considered to be a natural phytoestrogens. You'd have to be consuming a lot of soy or edamame to get the level of phytoestrogens you might need to be getting any relief from your menopausal symptoms. So it's not necessarily recommended. Diet was with respect to like insulin resistance, for sure. We talk about that a lot in generally in medicine, but not with respect to regulating your hot flashes directly, if that makes any sense. For sure, patients with a history of PCOS, for instance, with irregular periods that are related more to that cluster of symptoms, can have help with dietary modification, but that's sort of a different population than what we're talking about here.
Yeah.
Oh, I have a good question. What is the average age to start hormone therapy? And what are the typical symptoms that initially bring women to the hormone therapy table?
Usually, I would say either right before their last menstrual period, so 49, 50 is usually when I see, that 48 to 52 is where people would probably start, or avidly start. And it's usually hot flushes that trigger, the hot flushes that has caused some sleep disturbances or some mood changes. It still dominates what we see in women that come to us, and I can say that for decades, but it still remains those kind of how many they have and how disturbing they are to their lives. You'll see some mood stuff, but not as significant. It's not significant to bring women to our attention for mood changes in perimenopause. Not that they don't have it, but it's not as commonly seen as hormones being helpful for that. We're seeing more of that thought process now, I find, than we did before. So I'd say mostly it still remains the hot flushes and the lack of sleep. I'd say more the hot flushes that cause the lack of sleep seem to really push women right into that. I have to get something. I'm losing my mind. I can't work anymore, kind of thing.
Yeah, the I can't work anymore is a big deal. In the last year or two, there have been a lot of advocacy projects in the workplace to try to get big companies who employ a lot of people to pay attention to and to make accommodations for patients or people who are going through menopause. Because some very real changes in and ability to engage in the workforce in a meaningful way do happen around menopause, particularly untreated menopausal symptoms. So
yes,
yeah.
exactly. I agree.
So
Hopefully they'll make enough of a difference that women will be able to get more access to help.
definitely, even if it comes to broader insurance packages that can either cover private menopause care or my alarm went off to be like, we're out of time. To private menopause care, or even some of the more a wider scope of what medications can be covered, because we're often limited.
Yes, as to what we can prescribe.
Yeah.
And the Ottawa Hospital does have a plan. Someone asked that question. They do have, through the new CHI plan, some services that will help with managing different symptoms you may be having. It's not specific, I think, to menopause when I asked them about it, but for all sorts of other aspects of, maybe mood changes or other challenges, well-being challenges. But yeah, through our private CHI provider that's associated to the Ottawa Hospital.
All right, everyone. I think that's enough for tonight. We've covered a lot of information. Those of you, you're welcome to tune in again to our fall-based public-facing webinar. If you just need to go over things again, and I maybe ask a few other questions. I wanted to thank our sponsors again. That's Knight Pharmaceuticals and Searchlight, who made tonight possible and are trying to be an engine around educating women about their bodies, not only the work we do in puberty, but in the work we do in menopause. And I would just finally say that Helen and I work at the menopause clinic at the Ottawa Hospital, and largely right now I've had to limit referrals to complex patients who are cancer survivors just due to the sheer volume of wait time. So if you hear our names and you ask your physicians for referrals to our clinic, they might be turned away, and that's not because we don't want to serve you. It's just because we're focusing our efforts on the higher complexity. But we will circulate a list of names of clinics and reputable physicians who are doing this work as well. So hopefully you can go armed to your physicians, family physicians, to get referrals and get the care you need.
Yeah, absolutely.
Well, thank you so much, Helen, for putting this together, for rehearsing, for unearthing these presentations that you used to give commonly, and for sharing your expertise with us. We're going to conclude the session. And Marisa, is there anything we need to do?
That is it.
Okay.
Thank you so much.
Maybe do the three of us want to hang back after everyone signs off, or should we just convene in a different location?
I think we can convene.
Yeah,
Emily,
I'll end the session and then we can meet afterwards.
Okay, that's
perfect.
Fine.
Thank you so much, everybody.
Take care, everyone. Have a great night.
Bye.
Bye.
Oops, where am I?